Happy Thursday, everybody. I know you're used to hearing about bariatric surgery and weight loss surgery and dietary management and things like that. But what some of you may not realize is that our practice is a comprehensive upper abdominal practice. We take care of all sorts of disorders either associated with weight or not necessarily associated with weight in this practice, including gallbladder issues, hernia issues, and really significantly, because of our patient population, GERD issues or gastroesophageal reflux. So today we're going to talk about gastroesophageal reflux, some options, and the evolution of the treatment during the course of my career, which has been quite remarkable. Gastroesophageal reflux symptoms are heartburn, indigestion, sometimes a nighttime cough, sometimes a bitter or metallic taste in the mouth, actual regurgitation of stomach contents. It can vary from mild to minimal. 60 million Americans suffer from gastroesophageal reflux, and over 25% have symptoms every week, and 10% of Americans have symptoms of gastroesophageal reflux every day. So it's a very, very prevalent problem. So let's talk about some of the causes, and then we'll talk about some of the treatments. What actually happens in normal anatomy is your diaphragm is the muscle that separates the esophagus from the stomach. Where the esophagus joins the stomach is an area of a high pressure zone that we call the lower esophageal sphincter. It acts like a little flapper valve, and in a normal situation, food comes through the GE junction into the stomach. The valve stays shut to keep the food in the stomach and the stomach acid out of the esophagus. Sometimes something will disrupt the function of that lower esophageal sphincter valve. The most common cause that we see now is obesity. And secondary to the obesity, you can get what is called a hiatal hernia. That's a condition where the opening in the diaphragm allows a portion of the top of the stomach to slide up into the chest. When that happens, it alters the position of this lower esophageal sphincter mechanism, which makes it not function correctly. So it then allows the acid from the stomach, or in some cases bile from the stomach, to reflux up into the esophagus. When that happens, that's when you can get symptoms. That's also when you can get damage to the tissue in the esophagus. Not all symptoms are directly related to the severity of the injury, because sometimes we really have what we call strong host defense mechanisms, that you can have terrible, terrible anatomy and terrible, terrible function and minimal symptoms. Sometimes you can have severe, severe, severe symptoms and minimal tissue injury. So it's a very detailed, thought out process to determine the treatment for gastroesophageal reflux. We've known for several decades that surgery is a much more effective long-term treatment of the cause of gastroesophageal reflux disease. The problem was, prior to the 90s, the cure was worse than the disease, because it usually involved a large upper midline abdominal incision or even a chest incision or both, and so that was associated with what we call a lot of morbidity or complications or pain or suffering. With the advent of the laparoscopic revolution of the late 80s and early 90s, we took what was a surgery that worked, that was very morbid, and turned it into a surgery that was very patient friendly. That's when the surgical treatment of gastroesophageal reflux really evolved. Then why doesn't everyone have surgery for gastroesophageal reflux? Well, at the same time that our surgical techniques were getting better, we started discovering new classes of drugs that could treat the symptoms. And most people with a brain, if they can take a medication to control their symptoms, why would they willingly undergo a surgery? And that is the conundrum that we suffer with today. When is it proper to have surgery for gastroesophageal reflux disease versus medication? Sometimes the indications are very clear. If you have symptoms that cannot be controlled by any kind of medication whatsoever, then you should consider surgery. If you are on a medication that can have bad side effects, like the proton pump inhibitors, we really don't like seeing people on these for years and years and years of therapy. They're really meant to be taken for a short period of time and then get off of those drugs. If you have breakthrough symptoms and have to stay on a proton pump inhibitor all your life, that might be a time that you might consider having surgery. Another time when surgery might be considered are people that are having what I call atypical symptoms of their gastroesophageal reflux disease, such as a nighttime cough, problems with your vocal cords, chronic regurgitation in your sleep. These are things that drugs aren't quite as effective in treating, and surgery might be indicated. So, how do we sort out whether you're a good candidate for surgery or whether surgery will be effective for you? Then, how do we sort out which surgical intervention might be useful for you? The workup generally, always, like anything else in surgery, starts with a good history and physical examination, a clinical consultation. You come in, you see your physician, you discuss your symptoms, and then you come up with a diagnostic plan. You work through your diagnostic plan, and once you finish your diagnostic plan, then you come up with your treatment plan. The initial diagnostic choice frequently is an esophagogastroduodenoscopy, where we go with a flexible scope down through the esophagus, into the stomach, and into the intestine. We're looking at the tissue, the cells, to see, are they normal, are they abnormal, is there an ulcer, what's going on here? Is there a hiatal hernia? Do we see a hiatal hernia present that needs to be corrected? And if so, how big is it? How much damage is it doing? Once we've determined that the patient has symptoms and might be a proper candidate for surgery, we need to do confirmatory tests to prove that. The two most popular or commonly performed tests are a pH test. The traditional pH test, we put a probe down through the esophagus and measure what percentage of the time acid comes from the stomach into the esophagus. That's called a Demeester score. Patients don't like this test very well because they have a tube going down their throat. So recently we have a new test called a Bravo, where when we do your EGD or endoscopy, we place a little device implanted temporarily in the wall of the esophagus that records the same data that the traditional pH study does. So instead of walking around with a hose hanging out your nose all day, you just have this little transmitter that's in there that records the data, and then after a short period of time, it releases and just passes through in your stool. That's called a Bravo. We've been very pleased with the data we're getting with that because patients hate that other test. The other test that we do is we need to measure the function of the esophageal muscle, because not all reflux is traditional reflux. There are other conditions present that would preclude or prevent you from doing a traditional surgical intervention. This is called a manometry. It's really just a pressure test. There again, that involves a tube that goes all the way down and gives us data. Now we have, in some cases, another test where we can place and perform while we're doing the endoscopy to avoid you walking around with a tube hanging out. So the diagnostic phase has gotten a little bit more user-friendly. So let's say we've done all these tests, we've come up with a diagnosis of a hiatal hernia and reflux, and we need to do something about it. The traditional operation, which we consider a gold standard by which all of our other interventions are measured, is called a fundoplication, where we go in, we repair this weakness in the diaphragm with some sutures, then we take the floppy part of the stomach and wrap it around the lower esophagus, recreating that area of high pressure or that fist muscle. This is called a Nissen fundoplication. We've been doing this for several years. The operation has gotten quite standardized at this point, and the complication rates of the past have gone down over the last 2 decades with the advent of laparoscopy. Sometimes our preoperative workup suggests that we don't want a full or a 360-degree valve, so sometimes we will do a partial valve, and that is determined by the readings we get from our manometry studies or our pressure studies. Well, this isn't always what certain people like. So there are other options available for us. So there's a procedure called the TIF procedure, which is done completely transorally, where we go in and we recreate that little muscular zone through an endoscope. This is only for patients that don't have large hiatal hernias present. If you have a large hiatal hernia present, you still have to fix that hernia surgically. And in my personal opinion, you might as well do a traditional surgery if you're going to be in there and repair the diaphragm. There are other devices that are available that some of my associates are being trained on that we will wait and see. We're taking a wait and see attitude on how those go. One of them is called a Lynx, has a very promising future, but still the jury is still a little bit out on that. But that will be offered in our practice at some point. The summary of this is, if you're suffering from reflux, it can be signs of other underlying serious diseases. Come in, get an evaluation. Only probably 1 person out of 4 that we see really need a surgical intervention. Many of them need something else. So if you're suffering from reflux, heartburn, nocturnal cough, get in and see us, do a consult, at least find out what the cause is, make sure there's not other underlying serious illnesses. And if you are a surgical candidate, feel assured that in this practice we have over 30 years of experience in dealing with patients with reflux. Both Dr. Snow, myself, have been doing anti-reflux surgery since the 90s. And of course, Dr. Roberts and Dr. Novak, younger but very aggressive, and are leading the way with the newer technologies. So between the core of our surgical group, we can offer you all of the options that you need to get your reflux treatment started. Thanks for coming. See you next Thursday.